Boo. Boo.
All right.
It's Friday.
It is Friday. You can't put it off anymore, I swear. And I know that the sword of microbiology is now hanging over your heads, but we'll be all right. You guys are going to be fine. All right. So, glomerular filtration pressure. Okay. The pressure inside that ball of glomeruli is higher than the rest of the capillaries, and it's intended to be, because glomerular pressure needs to be high so that we can exert the filtration pressures to create filtrate, which then ultimately becomes urine. Okay, so depending on the diameter, the vasoconstriction or dilation of the afferent efferent arterioles changes the pressure within the glomerulus, which then affects renal blood flow and glomerular filtration rate, which we're going to discuss today. All right. So, efferent arteriole being a smaller diameter, even without, like at rest, at homeostasis, without any effect of vasodilatory stuff or vasoconstrictive stuff, the efferent arteriole is smaller, right? We've already learned that. The afferent arteriole, if you're looking at a picture, is wider in lumen. So ultimately, there is always a higher back pressure within that glomerulus. Does that make sense? So if in pipe is larger, the out pipe is smaller. There is a physiologic back pressure at standard without any kind of effect of the RAS system or any other thing. Okay? And again, that is so that we can make a filtrate at baseline. Now, changes in those diameters are going to alter how much, how fast the glomerular filtration rate occurs. Okay? So net filtration pressures, we're going to go over these today. This is going to be, like I said, very similar to what we already saw with the capillary pressures, right? But there's less of them, so that equation is actually easier, which is good. So, blood hydrostatic pressure. Hydrostatic pressure, you guys remember that from before? Pushing outwards, right? Pushing outwards. And that really is the net largest of the pressures, and that's created from that smaller diameter, the efferent arteriole, that back pressure I was just talking about, okay? Capsular hydrostatic pressure. That's the pressure that the filtrate within the Bowman's capsule space around the glomerulus exerts to push back in, right? So it is a back pressure, all right? So does that make sense so far? Blood pressure pushing out, capsular pressure pushing back in, sort of opposing forces, okay? And then colloid osmotic pressure. We know what that is, right? Those are those large molecules, protein mostly, but not entirely, mostly exerts the colloid. And which protein? Albumin, right? Albumin. Large molecule that's not supposed to escape those fenestrations or that filtration membrane because of its size, its physical size. It should keep it in. And again, if we talk about alterations in the foot processes, in the filtration mechanism, in the fenestrations, in the pressure within the glomerulus itself, then we can start to lose those albumin proteins into the filtrate, and then all of this dynamic is turned on its head a little bit. Okay, so as we come up with the net filtration pressure, it's blood hydrostatic pressure minus the opposing forces. The blood colloid pulling in, the capsular hydrostatic pressure pushing back in, all right? And the net filtration pressure is what we're left with. And again, what alters these filtration pressures? Changes in diameter, changes in permeability of the glomerulus itself. We'll talk about those coming up here, all right? Does this make sense? This is how we create the ultrafiltrate that's in the capsular space that makes its way into the proximal convoluted tubule and then down through the rest of the nephron, and ultimately becomes urine that ends up in the collecting duct. All right? And for those of you who are more visual learners, this is it, right? We have the one pressure exerting outward pressure to get the filtrate out of the blood, and then we have the two opposing forces pushing or pulling, okay? Clinical correlation on this, if you will, this is just one of many. Nephrolithiasis, so kidney stones. If you have a kidney stone that's obstructing the lumen, an obstructing stone, you can have an increased back pressure, so that's going to really net increase your capsular hydrostatic pressure, so you're going to have a higher force opposing filtration, so you can actually lose filtration altogether depending on the level of the blockage and the severity of the stone. Other things that you could have are something called nephrotic syndrome, which alters the permeability and allows albumin to escape. You can have nephritic syndrome, which alters the permeability because of glomerular inflammation and causes bleeding. So there's a lot of things that change this, all right? Back to the kidney stone one, if you have a long enough timeline where you have this severe obstruction, right? Any obstructive process can call this, but it can lead to hydronephrosis. And hydronephrosis is like I talked about yesterday. You have this normal renal pelvis here with this normal collecting duct. If you have long enough backwards pressure forcing the urine back in, or more accurately, preventing it from escaping, ultimately what it does is it pushes out this functional tissue, and you're left with a lot of non-functional renal mass. Okay? So chronic obstructive processes, one of the major risks is hydronephrosis. And hopefully that is a chronic kidney disease. That kidney's not going to recover that functional tissue. So whatever's left is what they have. So one of the many reasons we treat kidney stones and all these various nephrological disorders. But that's a bridge too far for right now. So anyway, pressures, understand the pressures, and you have to be able to calculate. We're going to ask you to calculate, the royal we, I am going to ask you to calculate that on the exam. Okay, just so you know. But again, simple, one formula, right? And only 3 numbers this time. Yes.
Is that what typically causes? Is it like prolonged like years of holding your pee when you shouldn't, or is that like
No. It's you're not gonna. It's a physical obstructive process. So like being an IPAP and being scared to go to the bathroom because you think you're gonna miss something is not gonna lead to hydronephrosis. But what is gonna lead to hydronephrosis is like benign prostatic hyperplasia or vesicular-ureteral reflux, like we talked about yesterday. Remember those physiologic sphincters, right, that pull down and close off the bladder, right? If you have reflux that goes up that way, eventually you get hydroureter and you get hydronephrosis. And it's, we're talking years, not even really months, like years of pushing out into that tissue. You can have a reactive hydronephrosis, like a very minor one if you have a kidney stone urgently. That's going to push out a little bit and just create like more fluid than there should be in the renal pelvis, but it's not going to destroy tissue the way that does. So that is like a years-long process. Okay. Prolonged obstruction, think about that. And whatever causes an obstruction in the dam, right? A dam in the river, you know what I'm saying? Okay. So glomerular filtration rate and renal blood flows. Intricately linked concepts, but 2 separate concepts. Yes, sir? You wouldn't necessarily feel pain. Well, so you had a kidney stone. Yes, you might end up having pain. But ultimately, you can have a very large obstructing stone that doesn't necessarily cause pain. You can have what's called the Staghorn calculus that just forms inside the renal pelvis, and it doesn't necessarily move, so it doesn't cause any pain. But symptom-wise, what you're going to end up having is a lot of polyuria, like going to the bathroom all the time, or hesitancy where you can't get all your urine out. Something that is indicative of obstruction. Or vice versa, something that's indicative of chronic infection, urinary stasis, right? Right, we talked about static fluid anywhere in the body is not good. So you're going to have overt symptoms somehow. It's not necessarily going to be. Most kidney disease, frankly, you guys, doesn't present as my kidneys hurt. Most kidney disease presents insidiously, and you find it on a random, BUN, creatinine, a random urinalysis where you're just like, this is wrong. You know what I mean? Then you go back and look at these patients' lab, and it's been wrong for a long time, but nobody's paid attention to it. Kidney stone, urinary tract infection, those are more urgent, but I think the prevailing majority of chronic kidney disease doesn't present overtly. You know what I mean? Does that make sense to you? Yeah. All right. Any other questions? So, glomerular filtration rate versus renal blood flow. All right? And the slides are going to explain it, but let's just talk about it. What do you think the difference is? I know you want to say something. Say it. Yeah, you man.
Me? Oh, shoot.
No, not you.
I mean, okay, good.
No, not you.
Not you.
You? No, not you either.
Oh.
Yes, you. John, yes, you. Come on.
I'm still confused.
Yeah, man. That's just fun. This is
I was
fun.
already talking and you said no.
This is fun.
So, renal blood flow.
No, not you guys anymore. Go ahead, dude. So,
GFR. Renal blood flow would just be like the actual nutrient exchange in your kidney.
I think I know where you're going.
Yeah. I don't know.
Yeah.
Disregard.
Good try. No, good try. I mean, I appreciate it. It's being put on the spot sucks, doesn't it? I hate it. Yeah. Anyway, put you on the spot. What's up?
Okay, I was just gonna say, so renal blood flow, just like the actual blood flow to all the structures versus like how fast the blood filtration rate is going.
All right, you guys are getting closer. Okay. Yeah, go ahead.
That's right. It's the amount of blood that the kidneys actually have going through it versus how much is being filtered out.
Here you go.
Is that?
It's how much blood makes it through the afferent arteriole into the glomerulus, and then in a given unit of time, versus how much blood gets actually filtered. Think of glomerular filtration rate as a percentage, right? Versus renal blood flow as the total amount. So total amount that goes through the glomerulus, even if it comes back out, is renal blood flow. What percentage of that actually gets filtered through as becoming ultrafiltrate, ultimately become urine, is glomerular filtration rate, all right? So, the amount of blood filtered by the glomerulus into the capsular space, right? Sort of the functional amount that the kidney squeezes out through the glomeruli into that capsular space to ultimately enter the nephron. Does that make sense, everybody? Okay? Ultimately, this process, right, the GFR is very closely regulated. It doesn't alter very much in a normal, physiologically functioning kidney. Now, we're not going to go into pathophysiology too much because then all bets are off. But in a normal, functional kidney, your blood pressure can jump quite a bit, and the GFR is going to stay very close to the same. And the reason for that is because if it allowed huge changes and fluctuations in blood pressure, the glomerulus itself could be damaged very easily. It's a capillary bed. You know what I mean? So regulatory mechanisms that we're going to discuss, tubular-glomerular feedback, and the myogenic mechanism, neuroregulation, so on and so forth, really control that afferent arteriole, control that in-pipe more acutely than the out-pipe, just to make sure that all of a sudden we don't have this huge rush of increased blood pressure into the glomerulus, okay? Renal blood flow per unit time. So again, think of this as the total amount that's flowing through the kidney. And the reason I did that, by the way, is because renal blood flow sounds exactly what you guys think it sounded like the amount of blood flow just flowing through the entirety of the kidney and giving the actual physical kidney parenchyma its nutrient. So that's why I said that, because it's not that. It's what's going into the glomerulus versus what's filtered through it. Is that clear to everybody? That concept? Yeah? I want to see some more faces. Yes?
What would you use to describe the actual blood that's used, like providing nutrients to the kidney? What would the term be?
That's not like that's just blood flow. That's that's just nutrient exchange. You know what I mean? Yeah. Yes, sir.
How do they test for, like, how do you find out people's GFR level?
Well, we're going to get to that in the next couple slides. Absolutely, we are. You can measure it directly. It is extraordinarily cumbersome and not very frequently done. And unless you're in a nephrologist's office, you're never going to do it. Most of the GFRs that we get, you're going to see an E, a small lowercase e, estimated glomerular filtration rate. And I'll tell you why in just a second. All right? So, again, 600 milliliters enters each kidney. We talked about the kidneys receive 1,200 milliliters, right? So both kidneys together, that's about right. So that's how much blood we're filtering. But a very small percentage, a relatively small percentage of that actually becomes filtrate, all right? Actually becomes filtrate. So let's talk about this conceptually. And it's going to help when we get to like the renin-angiotensin aldosterone system, all of that stuff. What exerts the pressure and where, okay? So afferent arteriole. Basically what this top picture is saying is if you constrict the inflow mechanism, both will decrease, right? Renal blood flow through the glomerulus will decrease, and thus filtration by the glomerulus will decrease if less blood is going in. Does that make sense? Yep. So, I mean, think about it. It's like if you have a hose on full pressure and you turn it down, less water is coming out. That's exactly what's happening. Less water, less blood is making its way into the glomerulus. So renal blood flow, total blood flow is reduced, and so is the amount that the glomerulus can filter, because it's getting less blood to filter. Does that make sense? Okay. Constriction of the efferent arteriole, it decreases renal blood flow, and why? It's sort of like an obstructive process. Exactly. Less blood is escaping. Because remember, renal blood flow is all the blood that comes into the afferent arteriole, makes its way into the glomerulus, and comes out the efferent arteriole, right? So if the efferent arteriole is constricted, less blood is flowing out. Thereby, it reduces the rate of unit blood that can go out per minute, per time, right? It's just an obstructive process. Does that make sense to everybody? Yeah? Okay. But it increases the GFR. Why?
More time.
You're right. You're all right. Everybody, more pressure, right? The outflow is constricted. Remember what I said. Even at a physiological homeostasis, without any effects, everything at the normal size that it is, the efferent arteriole is smaller, so there is always a back pressure there. Now that back pressure is increased, meaning that more stuff is going to be squozen out. Squozen. You have to use that. I love using words like that, like Miss Malacroft's like that, and they're like, people, sir, squozen's not a word. I'm like, oh. I know, I seem dumb, but I know that squozen's not a word. But it is now. All right, whatever you guys. All right, dilation of the, I want to keep an eye on this one. Now, do those two make sense, by the way? Do these two make sense? The first one's the one we just talked about. Okay. Dilation of the efferent arteriole only, right? So we have an increase in the outflow height. So, afferent arteriole is at its regular size. Now the outflow pipe, the efferent arteriole, is larger. So renal blood flow probably is going to be able to go faster, right? Renal blood flow through the glomerulus and out. But what's going to happen to GFR? It's going to decrease. And why? Because we have lost that back pressure, right? Right? And think about, again, the glomerulus is a filtration mechanism. The higher the pressure, the more stuff is squeezed out, right? In general? Yeah? Okay? Says never physiologically happens. That is true. There is not really an internal physiologic mechanism that does that, because it doesn't make any sense to do that. Really. We have other altered mechanisms to reduce our GFR if we need to, and you'll see those in a minute. But that does happen pharmacologically. And I'll put this in your brain now so that you know when you go in the future, okay? So, do you know what constricts the afferent arteriole the most? Afferent and efferent. Does anybody know? Angiotensin. Angiotensin 2. So the rest is, it decreases the size of the afferent and efferent arteriole, okay? However, the other thing that has a physiologic effect on the afferent arteriole is prostaglandins. They're vasodilatory prostaglandins. So if you give somebody something that blocks prostaglandins, like NSAIDs, and that patient is already on an ACE inhibitor, which blocks angiotensin converting enzyme, then they don't have anything that dilates the afferent arteriole, but you have a widening of the afferent arteriole. So you can induce renal injury, acute renal injury, if you're not careful with patients who are on those two fairly ubiquitous medicines. So that's why it's important to know what medicines your patients are on and what they do. Does that make sense, everybody? Physiologically, it doesn't happen. Iatrogenically, if we do it and we don't know what we're doing, we can cause a renal injury. Okay? Because then we have an ACE inhibition. We have ACE inhibition. It's not necessarily the efferent arteriole is vasodilating. It's just not constricting. So there's no ability. We have an open in pipe, a fairly open out pipe. What happens to the ball in the middle? The filtration rate goes way, way, way down, right? Because we have no pressure. Yeah.
This came into
No, that has to do with antidiuretic hormones. Or alcohol causes an insensitivity of the renal tubules to antidiuretic hormones. So then, game on. You know what I mean? You're just peeing all the time. You're not being able to really dilute your urine. Yeah. All right, and then dilation of the afferent arteriole, right? Which we can do, increases both. Again, so if we have an increase in pipe size, we still have a relatively constricted out pipe, we're still gonna have that back pressure, so both flows are gonna flow normal, right? Or increase, excuse me. Does that make sense to everybody? Conceptually, now this is just, again, this is a concept in a vacuum. We'll put more layers on it as we talk about the different systems, but just as everybody sort of get that, if what's increasing in size, what's decreasing in size, and what's gonna happen basically to the ball in the middle. Does that make sense? Maybe not at first, I mean, you're gonna have to probably chew on it a little bit, but conceptually as we're talking through it, does it kind of make sense to everybody? Sort of? Why is it important? Okay. You guys don't have to know this chart yet. You will, but not now. All right? So why is it important? That big red arrow points at glomerular filtration rate. So when we talk about diagnosing chronic kidney disease, we talk about two specific parameters, albuminuria and GFR. All right? So GFR is important as a parameter of how well our kidneys are working. Right? So we diagnose chronic kidney disease depending on GFR, depending on albuminuria, and depending on kidney size, evidence of kidney shrinkage or increase in size, depending on the disease process. But if you look at this sort of like Pokemon chart, right, depending on how good your GFR is working, and depending on how much protein you're spilling, basically, you're like, refer now, refer yesterday, right? So. And this is one of those things that I will tell students that I would have pinned up to my office wall, because I don't want to have to remember this. You know what I mean? But this is a good clinical tool for you guys to have eventually when you get into clinical practice. Say, okay. Because what happens a lot, and again, this is the soapbox that really maybe doesn't belong in anatomy and physiology, but too bad because I have a microphone. What happens with most chronic kidney disease is it gets overlooked for years and years and years, kind of like hypertension does. People don't pay attention. So you don't see the subtle changes in your BU and creatinine, you don't see subtle changes in your GFR. Subtle decline, right? So what happens is, like I was telling, overt kidney disease doesn't really present like chronic kidney disease, and I think my kidneys are failing. Find out your kidneys are failing when they have failed. You know what I mean? So primary care, us, you, our job is to pay attention to those lab values and find it here. You know, find it here, right? Not here. You know what I'm saying? Right. And this is very subtle. Kidney disease is very, very subtle. Okay? Anyway, back to your question, AA Ron.
I lost interest.
I don't even remember your question. I was just pointing at your name. I don't even think do you even go here?
Getting a lot of money.
All right. So, calculating GFR, how do we do it? All right. Estimated in general, because we're using parameters like creatinine to calculate. We're putting our our serum lab values plus other demographic parameters into a calculation and calculating it based on demographics and epidemiology. We're not actually measuring directly, even though we can. But by far, the prevalence, when you see it, you're going to see eGFR, so understand that. And when you get to nephrology, you're going to learn about other things that can help confirm or deny that as an actual sign of chronic kidney disease or not. The reason I have this on here is because you will no longer see race-based calculations, all right? You used to see on your clinical parameters, on your BNP or your CMP, you would see GFR black, GFR non-black. And that literally meant, is your patient a black patient or is your patient not a black patient? So the GFR used to be based on demographics of race, including everything else. Now that has been found to be unsound science, okay? And so we have a new non-race-based calculation, all right? So, I'm going to get to that in just 1 second. Again, it cannot be measured directly. It can. It can be measured directly. You have to basically inject this patient with a substance called inulin, not insulin, inulin, and you have to sit there and have them urinate in the office until it's gone, and we calculate their clearance. It's an invasive process, and it's not something that's done very often unless this patient meets several gates that we just absolutely have to do it, right? And that the we is the royal we of nephrologists who do this stuff, all right? This isn't something that you would even consider. If you're to the point where you think this patient needs this because you're confused about why their GFR or their creatinine clearance is going down, they should have been referred a long time ago. Just understand that it can be done, but for all intents and purposes in primary care, your GFRs are going to be estimations based on calculations, okay? Fair enough? All right. We use creatinine typically. Problem with creatinine is it's a nitrogenous waste product. It is highly variable depending on your patient demographic, which you go back to the previous slide, where we use things like age, race, or age, weight, body mass index, gender, because based on muscle mass, based on age, based on other things, creatinine can vary kind of wildly. So again, it's not a perfect estimation. So if you're looking at avant-garde nephrology medicine, they're trying to find a perfect one that can take, for example, from patient to patient. No matter what person in this room gets the lab test, it's going to tell you the same thing. Because everybody in this room, your GFR, your creatinine is going to vary just based on your physical person. Okay? So, ooh, God. Outmoded formulas, all right? So if you look at these, Krakow Galt, this was the vanguard when I was in school back in the day, all right? You will see Krakow Galt. By the way, you don't have to know any of these calculations. So this is for your G-Whiz. Krakow Galt, old calculation, includes race parameters, very, very inaccurate when it comes to like true GFR. Then they changed it to modification, MDRD, modification of diet and renal disease. A really weird name for a formula, but that's what it's called, MDRD equation. Became a little slightly more accurate. But ultimately now where we are is this. And I bring this up so you understand GFR and why it's important. When you get your clinical parameters, when you get your lab results, it should actually say, with a little asterisk, GFR estimated based on 2021 CKD epi equation. So you know that you're getting the best estimation of this patient's GFR. And almost universally that's the case now. I mean, unless you go to some tiny little rural area in the middle of nowhere, you're gonna get this. It's pretty much the lab standard now. Yes?
Are Black Americans more predisposed to kidney failure?
So that was the prevailing thought, but the epidemiology that was based on that was flawed in just the population density of the studies that they did. And so, yes, it's what it used to be. So you would, if you had said GFR black, GFR non-black, the black would be a lower value of normal, right? So you would get into abnormal at a lower value. Because it was thought essentially that, yes, they were more predisposed to have chronic kidney disease, but it was flawed science to begin with, which is why it's sort of entirely dismissed now, right? Which is why we take away the parameter, because the epidemiological studies have not borne that out at all. So, does that make sense to you? Yeah. So the answer to your question now, in 2025, is no. But old science would say yes, but the answer is just no. You're not more predisposed.
It's like old science 2020 because this is like 2021.
2021. I mean, heck, 2021. Come on, this is right.
No,
They don't change this shit every year. No, I mean, if you want to talk about mini revolutions, this is a huge evolution in science to break from that, right? So I don't know if it's on here, but there's an international organization called Kidney Disease Improving Global Outcomes. They're sort of like the international standard equivalent to the American Society of Nephrology. This was years in the making, right? The epidemiology is doing this is a years long study to create this, and then they create it as foundational science. Like this is the standard of care now. So yeah.
So like nephrologists, they've been practicing for a couple decades now.
Yeah, you might find it. I mean, if they're following the standard of care,
They would have.
they update. Like this is established. This isn't like theoretical. This is fact now. Does that make sense to you?
Yeah.
Yeah.
Thank you, sir.
No problem. Anybody else? Yeah.
Does that mean there's a significant population of misdiagnosed kidney disease?
More or less. Yeah. But on the flip side of that, everybody in the world should be on an ACE inhibitor. So, I mean, if you have a patient who's on an ACE inhibitor and they shouldn't be on it, it should be in the water anyway, so it doesn't matter. You know what I mean? So not as tragic, maybe, but probably what it's led. I mean, if you want to say what has it led to, it's led to a bunch of unnecessary studies, unnecessary CT scans, unnecessary IVPs, unnecessary CTUs, and so on and so forth. So that's the real negative outcome. But ultimately, the damage is being undone. Yeah. Does that make sense? Yeah. Seven.
Related to this, as a provider, how do you find out that, like, oh shit, we're doing this?
You got to still read. You got to read magazines, man. You got to read journals. You know. So you'll end up signing up for all kinds of stuff. You'll get journals for whatever subspecialty practice that you work in, A&P Ii journals, and subscribe to CDC, NMR, morbidity, mortality, weekly reports, stuff like that. There's all kinds of stuff that will inform you of this. It's why they call it medical practice, you guys. You know what I mean? The most dangerous person in any given medical facility is a person who thinks that they know everything. So you've got to stay on top of this stuff. Like, it sounds so, it's such a cliche to say graduation day is when the real learning starts, but it's kind of true. You know what I mean? So this stuff advances pretty quick. So, but you'll be on top of it. Right? You'll be on top of it.
Sir,
Yes.
so that 1.012 is just if that's for a female patient?
Yeah.
Why you?
Muscle mass, body size, because creatinine still varies. It's still a creatinine-based formula. So individually, muscle mass will alter creatinine. So what's normal for one person, that's one. All right. And, by the way, you don't have to know this, okay? You don't have to know this. The most important thing of all the things I just said is that race is no longer in the calculation. You will wrestle with this in the future, but in anatomy and physiology, it's just a point about why GFR is so important. Sorry for the digression. All right. Any questions? All right. So, what does affect GFR physiologically? We're not talking about pharmacologically. What does our body do to help regulate this GFR? As I said, within a wide range of systolic mean arterial pressure, honestly, within a wide range of mean arterial pressure, it's going to stay relatively stable because it has to, right? It has to. So what do we do? So we're going to go through autoregulation. What does that mean? Intrinsic, right? Intrinsic to the kidney. These are kidney mechanisms to regulate itself. Neuroregulation, we're going to talk about, again, like we have with many other systems, is sympathetic innervation. Okay? And then renin, angiotensin, aldosterone system. The reason why that's not listed in renal autoregulation is because renin, although it's produced in the kidneys, it's got to go elsewhere to ultimately make it as angiotensin 2. Okay? And then other hormones. So, autoregulation, this is the point I've said, but see, these numbers aren't necessarily definitive. It just gives you an idea of between a wide range of mean arterial pressure, it's going to maintain a kind of a flat line, just based on these autoregulatory mechanisms, so that we're not blowing our nephrons up. Because glomerular hyperfiltration, glomerular hypertension, leads to glomerular sclerosis, which leads to a loss of nephron mass, and that sort of becomes the sort of vicious cycle that ultimately leads us to chronic kidney disease. Okay. So we're here. If your MAP is 40, you're suffering. All right. So your GFR is not going to work. But when we get to about 80, right? All the way up to about 190-ish, we maintain a pretty stable flat line, just based on the autoregulatory mechanisms. Right? So we don't have this huge wide variation in GFR. So now, myogenic mechanism of autoregulation, just so everybody's following along on the slide, right? We're talking about the intrinsic kidneys mechanism. Myogenic, what does that mean? Muscle, exactly, right? Muscle. So we have a sudden increase in blood pressure. What's going to happen to the afferent arteriole? sudden stretch, right? It's going to contract in order to preserve the glomerulus, all right? So there's going to be a slight decrease, as we get a sharp increase in blood pressure, afferent arteriole dilates, then it vasoconstricts, so we have a brief reduction in GFR because of the reduction in blood flow to the kidney. And then some of the mechanisms that we're going to discuss coming up will stabilize the GFR despite the blood pressure, all right? It is a very intricate mechanism that has a lot of different permutations. We're going to talk about it at a very basic level, but does everybody understand that, at least for right now? We're not getting to everything else yet.
So this kind of same thing as the precapillary sphincters?
Yeah, you can think about it that way. It's not because there's not one there, but yes, it's kind of this. It's a very similar mechanism. Yes. All right. So now, if we have decrease, essentially we're going to have the inverse of what I just said. Decreased stretch, a decreased stretch reflex. So we're going to allow the afferent arteriole to open up. All right. And then everything's going to readjust based on some of the other mechanisms we're going to discuss to stabilize it. But again, overstretching of the afferent arteriole causes it to shrink down. Understretching causes it to allow it to open up, trying to maintain a relatively stable blood flow into the glomerular ball. Does that make sense to everybody? That's the myogenic mechanism. It is. It's myogenic. And what's the muscle we're talking about? The smooth muscle of the vessel. Okay? Does that make sense, y'all? Okay. So here's a picture for those of y'all who are more visual learners. Depending on, we have a sudden uptick in pressure. Our afferent arteriole kind of responds, feels that stretch, shrinks back down, right? Almost think of it like a spinal reflex, right? You hit your knee, it kicks, right? Stretches, it shrinks, right? Make sense? Now, again, we're still in autoregulation, but now we're talking about tubuloglomerular feedback. Feedback from the tubules to the glomerulus, right? Adjusting GFR, adjusting what the glomerulus is doing based on what's in the tubules. Fair enough? Okay. Hey, somebody keep me honest about break time, by the way. Because I forgot what time I started. So whenever it's time, just wave. All right. So juxtaglomerular cells. What do we say juxta means? Next to. By. Exactly. All right. They're around the afferent arteriole. Juxtaglomerular cells will expand, contract, very similar to the mesangial cell. All right. In order to change diameter of the arteriole, right? Macula densa, and I'll point these out to you in a picture coming up. They're in the DCT. Remember those pictures where the DCT is kind of right there near the glomerulus, right? Macula densa, they're sensing salt water concentrations in the tubules, right? Sort of telling it, is there enough or too much of either one in the tubular filtrate, meaning we need to adjust the glomerulus to fix that, right? It's a downstream effect, right? So by the time it's in the distal convoluted tubule, it's gone all the way through, right? But it's coming back near the glomerulus and giving it feedback saying, okay, something is wrong. We have too much salt. We have too much water. We have not enough, you know what I mean? So adjust to increase or decrease how fast we're filtering. Does that make sense? Okay. And then we have extraglomerular mesangial cells. Same thing as the intraglomerular mesangial cells, right? The intraglomerular ones are those ones inside the ball, right? These ones are just outside the ball, and they expand, contract very similarly, smooth muscle properties in order to help change diameter, all right? A very small role, just like inside the glomerulus, but it is something that contributes to GFR changes, okay? So, like I said, this is one of those ones, right? Proximal and distal, right? So just make sure, do yourself a favor. Better picture close up. Here we go. So that obviously we have the glomerulus in here. So this is the afferent arteriole. And these little blue guys are the juxtaglomerular cells, which can change size and shape in order to squeeze or contract, squeeze or open the afferent arteriole, right? Here we have the macula densa cells, right here, as part of the distal convoluted tubule, right? And then these little blue guys in the middle, they're the extraglomerular mesangial cells. All right? So all of these different cells have slightly different functions and contribute to the regulatory mechanism of the glomerulus. Right? Does that make sense so far? Okay. Yes, sir.
Do both the extraglomerular and juxtaglomerular both mostly cause constriction?
Mostly. They have similar but not exactly the same.
Is any of them going to die? Which one's going to dilate? Did it say? Or are any of them going to dilate?
Oh, we're getting there. We're getting to that, yeah. Here we are. So tubular glomerular feedback. As we have an increased GFR, right? So our GFR is going up. So the tubular, they're sensing that GFR is increasing, right? We're pushing more blood out into the making more filtrate, okay? If the macula densa cells sense that the rate is too high, the reason and the way that they sense it is that there's too much water and too much sodium remaining in the filtrate. Okay? Remember, it's not urine yet. When does it become urine? When it gets into the collecting ducts, right? It's still in the distal convoluted tubule. It's still filtrate. Right? It's still in the functional tissue of that nephron. So, as that filtrate is passing through the macula densa cells of that distal convoluted tubule, those cells recognize an increase in concentration of water and sodium, and in response, they release adenosine, which constricts the afferent arteriole and causes the mesangial cells to expand. Right? Remember I said constriction of the mesangial cells, it sounds inverse because you think constriction, but remember they're smooth muscle, so just think of the constriction of the mesangial cells more as expansion. All right? And what happens when the mesangial cells expand? They shrink the size of the tubule. They shrink the size of the glomerular capillaries. They shrink the size of the arterioles, right? Because they're taking up more space. Does that make sense? Kind of? Yeah? Are we still together, you guys? Do we need a break now? Are we good? All right. 3 minutes? Okay. All right. So again, in response to an increased GFR that is not allowing the remainder of the nephron to do its job, meaning there's too much sodium, too much water being excreted in the filtrate, or it's still in the filtrate, macula densa secretes adenosine. That causes expansion of the mesangial cells, okay? And it causes expansion of the juxtaglomerular cells, right? And it shrinks. And shrinks the size of the capillary and slows down the GFR. Yeah.
So it says they constrict, but you're saying they expand.
Constriction means it's like muscle constriction, right? So it's sort of like muscular flexion. It sounds like they're getting smaller, but they're pushing out against the barriers of each other and actually smushing the capillaries. So again, when it says mesangial cell constriction, listen. When it says mesangial cell constriction, I want you guys to think expansion. Okay, which is the opposite word. I understand, but conceptually, do you understand? Because then when you have relaxation, they shrink down in size, and it allows the capillaries to open back up. Okay, does that make sense? Even if it doesn't make sense, does what I just said make sense? Okay. Alright, again, it's because of the smooth muscle properties of it, right? Constriction, it means they're bearing down, if you will. Alright, does this make sense? This one right here? Too much sodium, too much water in the filtrate, macula densa, squirts out adenosine. Okay? And it slows everything down in order to equalize, meaning allowing the tubules more time to reabsorb that sodium and that water. We're going to get to tubular secretion and reabsorption in the next block, but for right now, superficially, got it? Okay. Decreased GFR, nitric oxide from the macula densa. And we all know what nitric oxide does, right?
Vasodilator.
Vasodilator. That's right. Other thing that happens here is the juxtaglomerular cells release renin. So when I ask you where renin comes from, you will know it's the juxtaglomerular cells. Here's what we got to do. We got to increase the GFR. How are we going to do that? Squeeze down stuff. All right. We're actually almost done for the day. You want to take a quick break and refresh and then come back and finish off? Well, you're the only one shaking your head no. So you can hang out, man, with everybody else. Just take a quick break. I'll take it 10 minutes. You got to be here till 5 anyway, don't you, today?
So, making sure products that you are internal to the strict, the easier it is to make that connection. They are not, yes. The adenosine is actually the yeah, they're just basically, they're like pushing into this space. They're the effector end, the effector that causes that. That's how you want to remember it, is like if you make, like, constrict your body. Trying to be like small shirt. But that's every time.
And just in a general concept, I'm trying to think of like generally when the afferent constricts, GFR is going to go down. When it expands, probably yes. Most likely, but that's kind of a general. Yes.
I guess I keep saying it, but then it's like hurting my head, so I'm trying to figure out which one. I keep saying it's or are you gonna, like, I'm just making sure.
For me, it's urine by the time it gets to this. And it's the reason is because it's still filtering, it's still deflecting, there's still water.
I'm just saying, that's like where does, so if the question were to say like, when does the kidney actually start producing urine? Is the question, is the answer going to be collected duct or is it going to be that's it. I'm not gonna continue down that. Yeah.
No, it's an exclamation. It can. There's an asterisk. Okay. It can. But in general, you're going to find most of this.
So they're in between afferent and efferent, right? Yeah. And then when they constrict, they're like this, and then they constrict down. I'm at dilating this. And when they constrict,
They're pushing
out. Like they're gonna decrease the size.
Okay.
So like the interior dermatitis, like when you bring it inside the veins, they're gonna shrink down. They're gonna basically shrink down the vessel size.
Just like Jake said, do some more because in my head I hear vasoconstriction, I think raise your blood pressure, but because it's also constricting.
Well, if it's think about it this way, like if it's vasoconstricting, there's less blood. I mean, I read my books. I didn't solve it. Sorry, man. Sit here. Wear a backpack. All of this.
Oh, yeah. Is that the one I sent you? There's one that I sent you that I was like, holy shit. It was a 4 handicap shot more than 4. This is Fat Perez right here. Oh, yeah. Dose. Oh, man.
Still about 300, like what is up with 300 side? special sense. Yeah.
I'm scared throwing us in. Huh? So I'm scared throwing us in. I'm about to. I blew my nose at least like 30 times this morning. Huh? So I blew my nose at least 30 times this morning. Just like, I'm down 8 pounds. I'm down 8 pounds. I can't keep anything in. I got shit like 5 times this morning. I already talked to Jake. I'm not going to. So I'm like, I'm not going to be around people. He was like, well, why don't you go home now? I was like, I got to pay attention. And me too.
Oh, really?
Try to eat something over lunch, but I got to figure out what I'm going to eat. Because I don't want to like, shit my brains out for A&P Ii.
No deals.
I know you don't like doing it else. You're like, you're ready to go now.
I should ask her.
Ready? Good enough? All right. Let's put a bow on this. If constriction of the mesangial cells, if the word constriction is hanging you up, erase it and write expansion, and you will have the concept, okay? And I'm not saying that tongue in cheek. I'm saying don't get caught in that word. Like that mental gymnastics sometimes is too much, and it is not worth getting stuck on. Just understand the concept, all right? That when these macula densa cells secrete their adenosine, it has a direct effect on the cells that make up the afferent arteriole, the actual smooth muscle cells of that vessel. Clamp down so that lumen gets smaller, okay? The other effect is to make these blue mesangial cells expand into the space of the afferent arteriole, further decreasing its lumen size. So you have an actual constriction, you have this other stuff pushing on the outside of it. Does that make sense? And then what is the net effect of that? Reduction in the amount of blood going into the glomerulus. Does that make sense? How it would then reduce GFR. Okay? And then when you go to the other slide, with the nitric oxide, the opposite stuff happens. These cells of the afferent arteriole relax and the lumen of that vessel gets bigger. The mesangial cells relax and stop pushing into that. So you get a widening of the afferent arteriole, meaning what happens to blood flow? More, exactly. Does that make sense, everybody? So please don't let that one stupid word trip you up and make you spend tons of time on these slides. The concept is what's important. Does that make sense to y'all? Everybody? I need something. Yeah, here we go. All right. All right. Now, neural control, sympathetic, okay, mainly. What we're seeing here, sympathetic innervation of the blood vessels, right? It's not just blood vessels of the kidney that are only supplied by sympathetic, it's right, most sympathetic stimulation of blood vessels in general. Okay? So, when we have normal, like this is normal ECF volume, right? Extracellular fluid. And where's the extracellular fluid? The interstitium and the plasma, right? Which is what we're really mainly concerned with. Then everything is sort of relaxed. Everything is at its normal space. Right? When sympathetic stimulation increases, okay, then we get an effect on the kidney. Sympathetic release of epinephrine, norepinephrine, right? We still know that. Fight, flight. Those are the catecholamines that come from where?
Adrenal.
Huh?
Adrenal
The
medulla.
adrenal medulla. Proud of you. All right. So, vasoconstriction of the afferent arteriole. What happens? GFR goes down. Renal blood flow goes, right? The end pipe is squozen. So, not enough blood can get in. Or less blood can get in, I should say. All right? And then ultimately, this is an immediate mechanism, sympathetic stimulation. Ultimately, a lot of these other autoregulatory mechanisms will stabilize and regulate the GFR back to its normal rate. Okay? All right? Does that make sense? Anybody? No? I see you. All right. Yes? Say it.
Yes.
All right, good. Now,
Ooh.
here we go. All right, so these cells, we already know, secrete our renin, our juxtaglomerular cells. Right? Told you everything has to have two names. I believe everything that I have calls them juxtaglomerular cells and not granular cells. So in this one case, we'll go with that one terminology. All right. So what does it do? How does it start? How do we start? With renin release from the juxtaglomerular cells. And then what incites that response from the kidney? So basically that question, what is the question asking what stimulates RAS? Low blood pressure. What causes low blood pressure? What mechanisms are going to have the kidneys recognizing a decrease in pressure, either renal blood flow or glomerular filtration rate? What's going to respond because of low blood pressure? So, low afferent arterial pressure by renal baroreceptors. And what do baroreceptors do?
Pressure.
Sense pressure. Exactly. Okay? Decrease in sodium chloride concentration. Okay? Right? Luminal sodium chloride, let me define this for you. In the lumen of the tubules. So just like we just talked about, it senses a decreased GFR, right? It causes the expansion of the afferent arteriole itself, causes the relaxation of the mesangial cells, okay? Because of the nitric oxide, right? What was that in response to? A decreased concentration of sodium chloride and water. Okay? Remember, it's tubuloglomerular feedback. So it's picking that up in the distal convoluted tubule that it's gone all the way through, and there is not enough. Okay? So GFR has been reduced. So we're going to have to raise it somehow. And then, just what we just talked about, sympathetic stimulation. Okay? Sympathetic stimulation raises blood pressure, right? Beta adrenergic receptors. Anybody know a medicine that counters the effect of beta adrenergic receptors? Beta blockers. There you go, right? For those visual learners, here you go. You can take a look at this at your leisure. Okay? So, ductal cells, one of those three things happen, right? One of those three things happen, so we're secreting renin now. The beginning of the renin-angiotensin-aldosterone system, okay? So let's get all of that straight. Angiotensinogen, okay, is made by the liver. Oops. There we go. Liver cells, okay? And angiotensinogen renin turns angiotensinogen into angiotensin 1. Yes?
Before we go, backing up, all three of those things have to happen?
No.
Or just one?
Any one of those things. Yeah. Oftentimes you will find that they happen in concert, but any one of those things can cause an increase. It can turn the RAS system on. Yes. Okay. So renin encounters angiotensinogen and then becomes angiotensin 1. Okay? Angiotensin 1 then becomes angiotensin 2 in both the lungs and the kidneys via angiotensin converting enzyme, ACE. You guys are probably all familiar with ACE inhibitors. That stops this process. That's how we lower blood pressure via an ACE inhibition. Okay? But angiotensin converting enzyme turns from 1 to 2. And then 2 is our active product. Angiotensin 2 is our active product that is one of the most potent vasoconstrictors in the body, physiologic vasoconstrictors. Okay? Happens in the lungs and the kidneys, which is why it's not, remember I said it wasn't listed on that intrinsic mechanism, it's not entirely intrinsic to the kidneys. It has to go elsewhere. It has to go to the hepatocyte. The hepatocytes have to make the angiotensinogen. It have to go into the lungs to get some of that converted into angiotensin 2. So it's not entirely intrinsic to the kidneys. It's a minor point, but I just wanted to be clear about it. Okay? Deep breath. All right? Angiotensin 2. Initially, it decreases the GFR because it vasoconstricts the afferent and efferent arterioles. Okay? It has a potent effect in the efferent arteriole to increase back pressure. So once the autoregulatory mechanisms kick in, GFR will return to normal. However, the remainder of the systemic circulation will be under a higher blood pressure. That's ultimately the net effect here. But focusing just on the kidneys, okay? If we decrease the GFR, ultimately more volume is kept in systemic circulation. You remember the difference between GFR and renal blood flow. GFR is how much is squozen out. Renal blood flow is how much makes it all the way through. So if less is squeezed into the capsular space, that means more remains in circulation. So ultimately, we're not squeezing out that plasma fluid, that extracellular fluid into the capsular space. We're keeping it in the plasma volume, so we're increasing blood volume, helping to increase blood pressure. Does that make sense? Everybody?
Yeah.
You don't have to keep saying this. All right. And then we're enhancing sodium and water reabsorption. Remember tubular secretion versus reabsorption. Which way is reabsorption going? Back into the blood, right? And then we have already talked about the fact that salt typically follows water, right? Okay? Huh? Yeah, the other way around. Water follows salt. Okay. All right. So water follows salt. Okay? And what's the back half of this? Aldosterone system. That's what aldosterone does, right? It works on different channels that we're going to discuss in the next lecture, but it keeps sodium and it keeps water. All right? With that increase in reabsorption of water with that decrease relative of GFR keeping more of the plasma in the vascular space. What is the net effect? Increased volume, which then increases pressure, right? Make sense? All right. I thought I told you to say yes when it made sense.
I wasn't listening, I'm so sorry. Show's getting really good.
If you see version B on your exam, just ignore it. All right. Now back to our friend, antidiuretic hormone. Where does it come from? No, it doesn't come from the posterior pituitary. It comes from the hypothalamus. And it is stored in the posterior pituitary. All right? All right. And then now enhancing the water retention capability, right? This one just holds on to water, right? It opens different channels that just allow more water reabsorption. Ultimately, this is our net effect. More blood, more pressure. Okay? Now, I know that that doesn't make sense on the first go around. The RAS system is notorious. It's going to take a few times to chew on it. But anything super confusing about it right now? Anything that just stands out like it doesn't make sense? Okay. All right, good. Here's a picture for you, visual learners. And here's some clinical correlation for you. So, the RAS system still active in a hypervolemic patient, somebody with hypertension, somebody with heart problems, right? It's because of the overstimulation of the beta-adrenergic receptors. So remember, any one of those three things can turn it on, all right? So even in hypertensive states, the RAS system may still be chronically turned on. Another example of that would be renal artery stenosis. Right? High pressure system, low pressure relative to the, you have the blockage in the renal artery. So you have a relative low pressure behind it, relative high pressure in front of it, so behind it being towards the kidney. So the kidney is still reading that it's not getting enough blood, so those beta-adrenergic stimulation is still there, so the RAS system is chronically turned on. So renal artery stenosis is notoriously hard to treat medically because it's very resistant to all the drugs that we have, right? ACE inhibition, right? We already talked about this. So we get all the way back to the ACE angiotensin converting enzyme, turning 1 into 2. We stop that process, then we stop the active form of angiotensin. We stop angiotensin 2 from being created. That's how ACE inhibitors work to lower blood pressure. They halt the process, okay? The thing about ACE inhibitors is that they increase something called bradykinin. So when you get to pharmacology, you'll learn about one of the main side effects of, one of the most notorious side effects of ACE inhibition, ACE inhibitors, is a chronic dry cough. And it's because of an increase in bradykinin levels, right? Bradykinin stimulates a cough reflex. And so these patients will come to you a couple weeks after you put them on an ACE inhibitor complaining that they have this cough they can't get rid of. And they're not sick. Like it's not an illness, it's just the stimulation of the cough reflex because of this increase in circulating bradykinin. So we switch them to an angiotensin 2 receptor blocker. So instead of stopping the production of angiotensin 2, we block the receptors so it can't do what it's supposed to do. Then these patients don't have that chronic cough because that doesn't increase their bradykinin level. Okay? That's just how the two things work. Yeah?
Why would they not prescribe this initially?
Because they're more expensive. And that's why. Yeah. Initially when they came out, ACE inhibitor, lisinopril is dirt cheap. I mean, honestly, valsartan is pretty cheap too now, but most of the time our first line go is just to. Also, ACE inhibitors are slightly more efficacious. All right, but when you get to the person who just cannot tolerate it, then you switch them to this thing. So that's pretty much why. Most of the answers about why we won't give them a better medicine first is because of a dollar sign. Right? If you look at a pharmacopoeia, you'll see how many dollar signs each little thing is. Right? So you have a $2 sign thing, especially in the Army. DHA doesn't want $2 sign things or $3 sign things. They want $1. They want like the cent sign. That's what they want. So if there's an older, cheaper medicine, that's it. You know what I mean? Hormonal regulation. Okay, so back to GFR mechanisms. This is hormonal regulation now. A&P, we talked about that before. Stimulated by the stretch of the atria, right? This one dilates the afferent arteriole, constricts the efferent arteriole. Okay, what's that net effect going to be? If it's going right, it dilates, so it opens the in pipe and it closes the out pipe. The ball in the middle receives a higher pressure, so it's going to increase our GFR. That's right. Okay. Nitric oxide, we've already talked about what that does. Okay. Vasodilation. Bradykinin. Minimal, in the absence of an ACE inhibitor, right? So just in naturally occurring bradykinin. Minimal contribution to GFR regulation, but it still is there, so we talk about it, okay? Adenosine, talked about that one, okay? Endothelium, haven't discussed that one yet. Vasoconstrictor. Paracrine effect, right? Autocrine and paracrine effect here. It has effect on the cells that release it and other cells nearby, okay? Ultimately, it reduces GFR because it causes vasoconstriction. All right? So these are just the sum total of the hormones that have an effect on GFR. Any questions for me? That's enough for one day. I have some questions for you. But any questions about anything today? We talked about filtration pressures. We talked about GFR as a concept. We talked about calculations of estimated GFR. Talked about all of the different mechanisms that regulate GFR, right? Autoregulatory mechanisms, hormonal mechanisms, neural mechanisms. Never mind, you know what I'm saying. Anyway, any questions? Yeah.
It might be trivial, but if you constrict the afferent when going into it, would it not increase pressure? I think about
No.
arteries or something when we constrict them and it increases blood pressure. I can see how that would trip me up. Like, why was it not?
Because you're not constricting the entire thing. You're not constricting the entirety of the glomerular capillaries. You're constricting the afferent arteriole. So basically, just less flow is coming to the glomerulus. So there may be back pressure. What you're talking about is like the precapillary sphincter type thing. That increases the back pressure to keep systemic pressure high. In this case, we're talking about downstream effect. So essentially, if you dam the river, less water makes it pass. That's why inside the glomerulus, we have a reduction in GFR because we have less pressure, right? And then ultimately renal blood flow too, because less blood making it in, ultimately. So it's a downstream effect versus an upstream effect, which is what the precapillary sphincters do. If you want to think about it the way that, think about it, the afferent arteriole. Now that squeezes down. Now we have that back pressure effect that increases glomerular pressure.
I guess I'm just thinking about the rate of blood being pushed into the glomerulus.
And it
Putting it through a smaller
decreases,
tube would-
right? It decreases. It's not like putting your that's why we talk about hemodynamics a little bit, right? It's not like putting your finger on a hose and it squirts out far, faster and harder. It's not. That's not what happens with hemodynamics because it's a mixed fluid, right? It's not water, right? So less blood flow coming in causes less pressure in the middle. All right. Any other questions? All right. A couple of these and get you out of here. What's the visceral layer? All right, doesn't matter if you don't know what the visceral layer is. The filtrate basically this is asking what is the pressure exerted by the filtrate that exits into Bowman's capsule?
Capillary hydrostatic.
Huh?
B.
Capsular hydrostatic pressure. It's the pressure of the fluid that has been frozen out, pushing back in. Okay? Word of the day. So something from the tubular capillary and put into the renal tubule. So from the blood into the filtrate, right? So we're going from blood to urine, not from urine to blood. What is that one called? Tubular secretion. Yep. Tubular. A lot of mumbling. You've had too many questions for the day already? Filtration. Glomerular blood hydrostatic pressure. Blood colloid osmotic pressure. Alpha delta. Bravo delta. Capsular hydrostatic pressure. I won't do this on the exam. I'll give you anyway. Which one promotes filtration? Which one promotes an outward pressure? A, right? Because this is a pulling in and this is a pushing in. So that would resist filtration, right? Whew. This is why we didn't do this yesterday. All right, what's up, everybody?
On that question before, how is that not capillary?
Because we're talking about tubular flow. We're talking about things moving in and out of the tube here. It's called tubular secretion. I hate to break it. I didn't mean it. Why is it not called capillary secretion? I don't know why. It's because we're talking about tubular secretion and tubular reabsorption. We're talking about movement through the nephron. Just get that nomenclature straight. All right. I don't have a good answer for that question about why is it not called that. It's just not.
So then if it was going from the tubular
It's tubular secretion and tubular reabsorption. Yep, straight up. Yep. And again, it's talking about the process of making the filtrate or reabsorbing from the filtrate. The milieu here is not necessarily the blood; it's more what's going into the tubule to ultimately become urine. If that makes it clear. Again, I'm not being snarky. I don't have a good answer for why it's not called that. It's just we're talking about tubular movement to or from the tubule. Okay, so focus in the kidney. Focus on what's happening in the tubule. Take it from there. That may be easier that way. Okay. Anybody else? Okay, guys. Thanks a lot. Stay fresh, cheese bag.
Stay fresh.